Welcome back to rpe.podcast, episode 6. So we've just finished chatting things about lateral or all ankle sprains. So now let's start talking about some other pathologies that can happen either concurrent with or after or completely separate to ankle sprains. So Scotty, where do you want to start here? Do you want to go to the plantar fascia?
Yeah, I mean, you can kind of group plantar fasciitis and Achilles tendinopathies in a similar boat, I think, in the fact that they're generally both overuse injuries.
Yep.
And in the initial stages, what you really want to do is work out how they were overused. Or, you know, I guess firstly, what their risk factors are. You know, are they a younger person and an athlete, and it's a training load issue or a training volume thing, or are they, you know, are they an over 60s female with diabetes and diabetes? You know, you're gonna treat them both a different way, but at the end of the day, the load on the tissues is over and above what it is able to tolerate.
I was gonna say with even with the diabetic female, even though the risk factors are different, it's the same thing. It's just an overload of the volume load for whatever she's done over the last little while has been too much. Same as it's just too much down here versus an athlete was too much like way up there kind of thing.
Yeah, exactly right. So I guess the first thing is to education on if there was a particular event or load that was too much that set it off, and reducing, I suppose, daily or weekly training load, whether that's through not as many sessions or reduced time in sessions, but maybe same intensity, or just even advice about rest. I think tendons are particularly important, like the rest of the body, that they need rest. You know, it takes, if it's a fairly strenuous sort of stimulus on the tendon, it takes 36 to 48 hours for that tendon to fully recover. And if you just continually just banging away at it, it's going to get sore. It's going to get sore. So if it's reactive, taking away that stimulus, giving it a bit of a spell, maybe you might give some information on footwear, heel raisers, orthotics. All those can work really nicely to offload some of those structures. I think in the short term, or changing, you know, training load if it's an athlete, changing stimulus, changing exercise a little bit is a nice way to start. If that doesn't,
if you're talking like the SRA cycle, I guess what you've just said, like your kind of all of those interventions are dealing with that recovery side or decreasing the stress. Basically, it's either promoting recovery by relative rest, by kind of using protective things like orthotics, or taping to decrease the stress on the tissue or increase its kind of rest, or for lack of a better word, I guess.
Yeah, exactly right. And if that, you know, if things are settled down with there, it's reintegrating back into whatever their training program was. Not going 100% back into it, maybe sort of stepping it up by a bit so that they don't go and overdo it again. If it's still sort of hanging around and you need to train it a little bit, it's considering, I think there's value in sort of like heavy, slow resistance training of a tendon to help make it stronger, make it more tolerant to loads. I think going through that is quite nice. If you had access to that, if you've got weights yourself, or if you've got access to a gym through your club or privately, there's definitely value in that. But at some point, you've got to get back into running and trying to work on that stretch shortening cycle of the tendon and work on the elastic component. So running or plyometrics or something like that, and chipping away at that until, you know, they're doing more than what they need to on a daily basis.
Yep.
Yeah. So that could be. Look, I love barefoot work. You've got to be really careful on who you get to barefoot work, because it does put a whole lot more strain on the tissues of the foot and the ankle, but nothing else will give you a same kind of stimulus to those structures as barefoot running. You know, whether it's slow speed, low sets, low rep, low volume, as an adjunct to what you're already doing, and then just building that up as you kind of can, as you can tolerate. That'd be just in the real sort of late stages. I sort of recommend when you just got a real niggly sort of pain, 2 out of 10, maybe a little bit of stiffness the next day, and just chipping away at that, maybe twice a week tops with your other training.
And even I guess you can't back that barefoot work, say in things like balance proprioceptive drills, even in resistance training drills, with good external cues to be able to keep a nice arch. Well, you can kind of low level load them relatively early as a way to kind of prepare them for what is coming a bit later. Yeah. So that's a good point. That's a really nice place to start. I don't focus on maintaining an arch, consciously trying to maintain an arch too much. I think if you do the right exercises, it will come. Yep. So even if you look at a calf raise, single leg calf raise, if you look at their foot posture on the ground, and then as you come up, just by the nature of coming up and the windlass mechanism and the muscle of the foot, it turns into a really nice arch, and then coming down again. Maybe trying to maintain that arch as you come down. So that's about as far as I go. Moving on to tiptoe walking, again, you're making sure the muscles of the foot there are working in that sort of reduced base of support, having to work a whole lot harder, just tiptoe walking forwards, backwards. The bunny hops we talked about a bit earlier, adding a little bit of extra body load onto that, so bouncing on it, making the tendons work a little bit more. I think just trying to maintain the arch or just the foot form functions, I think they have their place in sort of early to mid stage rehab, but what you're more or less doing is just active range of motion. And we don't tend to strengthen other muscles just through unloaded active range of motion. And I think that's where getting in tiptoes, doing some bouncing, doing some jumping, hopping, walking, running, barefoot, adds that extra load on those muscles, makes those tendons work in an elastic kind of fashion, which they're designed to, which you don't just get out of, you know, calf raises or foot form exercises with balance. I think if you want to work proprioception, that's fine. You're doing it for proprioception reasons, good, go for your life. But I think if you're trying to strengthen the arch, I don't think that's good enough. I don't think that's strong enough if the intent is to strengthen it. Well, because I guess you're not going to reach failure even under that kind of 30 reps, you're still not going to be reaching failure with a lot of those things, that it's not even going to be like a hypertrophic kind of stimulus. You need to, if you want to do it, you'd have to do something where the arch is going to fail kind of its ability to do that within you know, that 15 reps to be getting somewhat of a strengthening stimulus. So yeah, that's why a lot of those interventions aren't particularly strength interventions. They're more, as you said, proprioceptive or something like that. Yeah. Yep,
definitely. And I think the other thing is, you know, if you've only got body weight on it, or with movement maybe it's a bit more than body weight, how well does that transfer across to running, which, you know, is depending on where you look, 5 to 8 times body weight through that ankle joint or through the muscles that they have to work. You know, it's not enough. It's a good start, but it's not enough.
So interesting. Say, like you were saying, so it's awesome. Like you really do like to go towards a specificity kind of side of it. How are you against kind of bringing that in early in just little micro dosing? Like say when they are still quite acute. Like I know I've always been under the impression and always done more of a linear kind of progression through doing like isometric and then kind of heavy slow and then up into kind of plyometrics, etc. But there's another little bit of a thought out there that why not kind of micro dose that little stuff, almost like an undulating periodization, just micro dose that stuff in almost from the start, as long as it's not creating big flare-ups.
Yeah, I think there's a really good argument for that. I don't tend to do it too much. Probably the way I'm set up to work in the public system, generally can only get people in every 2 weeks sometimes a bit longer, sometimes a little bit less. And so unless you've got a really knowledgeable patient that has a really good body awareness and really good idea or ability to understand what's too much on their body and what's not enough, for me, there's just too much risk someone will overdo it and then set themselves back a little bit. So I tend to favour that linear progression. But you know, if you're working in a club sport and you're seeing this twice a week, sure. If you're an S&C coach and you're seeing these guys 2, 3, 4, 5 times a week, look, sure, there's probably no reason why you can't do that, because you can monitor them better. You can go, how'd you go with that yesterday? How'd you go with that 2 days ago? Yeah, good, pull up, great. Or bit ginger today. And so then you can modify that a whole lot easier. So I think there's a really good argument for that microdosing. I think there can be practical issues with it depending on what your client's like, depending how much contact you have with your client and how you can monitor it from there, I think. So getting back to the original question about plantar fasciitis and Achilles tendon issues and training that, I think it's really about making sure they have good range. So that's 15 to 20 degrees total dorsiflexion, making sure that they've got reasonable mobility through the subtalar joint, making sure they've got good first metatarsal dorsiflexion. I like to aim for about 45 degrees or whatever the other side is. If you don't have that ability to dorsiflex that first metatarsal joint, it's kind of like walking with flippers or walking big shoes around. You've got to generate either more force through the calf and Achilles tendon to get over that hump, or you've got to chase other ways to find mobility. And usually that's through internal rotation of the tibia, pronation through the midfoot, maybe external rotation of the hip. So you're sort of rolling over on the inside of that metatarsal joint as opposed to over the first and second metatarsal joints when you walk. And so that adaptation causes, depending how you adapt, can be a contributing factor to Achilles tendinopathy or plantar fasciitis there. So if you make sure that they've got good range and they can use that range in good biomechanics, that bio part of the biopsychosocial model, and then strengthen up plantar flexion with a little bit of bias on maybe inversion and eversion, that's a really nice way to start. Starting with your TheraBand if relevant, double leg calf raises, progressing to single legs, progressing to slightly more plyometric activities like your bunny hops, or progressing from double leg to single leg to maybe moving forward to running to sort of arc type exercises to cutting exercises to repetitive hopping, something like hopscotch or skipping is a great way to get that bounce. Skipping is really great, I find, for loading through the whole lower leg, not just the foot and ankle. And training that way and managing load along the way, I think, are the keys to treating all of these kind of overuse injuries where there's a plantar flexion ability or a stiffness, a dynamic stiffness issue with the ankle. I think, it all comes down to the same boat, the stress is on different tissues for different reasons.
I reckon you find an interesting thing here where the two kind of sides of physio, well, unfortunately, I'm dichotomizing it here, but where the people who are really psychosocial versus really biomechanics here, like some would go, hey, look, we need this dorsiflexion, we need this, we need your great toe extension, etc. And the others would say, well, look, we can just play with the volume loads and allow it to adapt. Basically, it's all just, no matter what, all it's doing on both sides is just adjusting the stress to the tissue realistically for a certain period of time to allow the adaptation. So whether you're doing that by getting the biomechanics to be the same as the other side or as close to as possible, therefore you're going to be putting less stress onto different tissues or just spreading the stress differently over tissues, or you're managing it via going, okay, we're just going to really play with the volume loads like crazy here. Again, the same thing. You're just playing, tinkering with that stress recovery adaptation cycle, really. So there shouldn't be all the targets. Everyone's doing the same thing.
Yeah, exactly. And I think the best argument or the best example of just building tissue tolerance is I'm going to butcher the name, but I think it's the long distance runner Haile Gabrielsi.
Yeah.
And you look at slow motion footage of what his foot and ankle does, and it's a hideous amount of pronation. Like if you saw that in the clinic, you would go like, that's wrong. This, and this. Yeah, he's one of the world's fastest men at long distance. You know, so there's a certain amount of tissue adaptation that's happened with that, and I think it's about finding that window or that envelope of function and maximising that through range, through loading, through both, and chipping away at that. And if there's any sort of psychological factors impacting on that, addressing them as appropriate. Sometimes I think physical conditions cause psychological problems. Well, I know it happens, and so trying to address those psychological problems there. I mean, I'm not a psychologist. I'm not really qualified to do that. If I can change the physical aspect and that changes the psychological aspect, great. But sometimes it goes the other way as well. Getting help. A great example of that is I had a lady who was an over 60s female, obese lady with diabetes. We've been cracking away at foot, doing all this sort of stuff. She's not running. She wasn't anywhere near that point. But all the other stuff, offloading and training and things like that, for about 6 weeks, not really getting anywhere. And then the next point she came in and she had a big smile on her face and she just looked like a different person, right? Like just something had changed. What's she's like, my pain's great, I've had no pain, it's fantastic. So what's changed? Something's happened between the time I saw you last time and now. Like, you're doing great, like, it's great. What's happened? And she said, I've met someone. I've met a fella. We go for walks on the beach, and for her that was it. All the stuff in the world didn't make a jot of difference. Finding someone, we're in a happy mood. Walking became enjoyable, and it fixed up.
Wow.
So sometimes there's little things that there's nothing you can do about it. It just stuff happens. So yeah. So that's the psychosocial aspect of it, I suppose.
Anything to add there, Connor?
On the whole kind of front of your tendinopathy or your fasciopathy overuse injuries, the literature just shows us that it needs some sort of load and it needs to adjust some sort of load, which is kind of reassuring for us because what doesn't work for one person, whether it be heavy slow resistance or stretching or finding a partner, may well work for someone else. So I think it's important to manage the loads, but everyone will have things that they kind of like more than others or will respond to better than others. So I've found especially with you guys talk mainly in a rugby league context or a field sport context, but with say I have a few runners come in with Achilles tendinopathy or your plantar fasciopathy or heel pain, whatever it may be, but they still get similar responses to heavy, slow resistance training, which is obviously loading the tendon a lot, and same with stretching. And I find that pretty interesting because a tendon doesn't really know whether you're heavy, slow resisting it or you're stretching it. All it feels is kind of tension, and it's just the amount of tension that you give it overall. It may work differently for the runner. If the runner doesn't get into the gym, I'll give them a stretching program. But if they go to the gym, then I'll give them heavy, slow resistance. And I think it's good because obviously you guys work with rugby league and whatever else. You can get them in the gym and they enjoy it and all that kind of stuff. And it probably helps you auto-regulate as well because you guys have more than one contact point with them. You can teach them early on what to expect with the heavy, slow resistance, or like you said, adding in those high demand tasks with a undulating periodization. Whereas if you only see the runner in public system, or whatever it may be, once or twice a week, and you give them a stretching kind of protocol, the literature actually backs up that they'll probably still get a similar result. So I don't know, it's kind of weird. You can do either thing, but as long as you monitor how much load they do and give them, again, some sort of load or some sort of tension, through either of these injuries, they seem to get better. Have you guys kind of found that, or?
I haven't done a lot of the stretching, to be honest. I've mainly done it through loading, through exercise. But I mean, it's a good point. I mean, you're right. Like the tendon doesn't know if it's stretching or if it's contracting against the muscle. I think eventually you've got to build up to that elastic nature of it, whatever way you go, whether it's sort of having a go after you've done a progressively low stretching program, going to sort of more ballistic type exercises, or even heaven forbid TheraBand work, which pulls it a little bit more, but you've got that ability to contract against it as well. Yeah,
or just their running volume loads as well. Like, I mean, you're stretching alongside their running and just playing with their running volume loads being there. I think the other lower limb that you were going to talk about was Achilles ruptures.
Yeah, look, I find them really hard. And I guess bear in mind, the sorts of ruptures that I generally see are people over the age of 40.
Yeah.
So, yeah. So, I mean, they're also really hard because the tendon is something's led to them rupturing in the first instance, whether it's, playing sport they're not accustomed to, child's athletics day and the daddy-daughter races come up and, daughter's on the shoulders and been for a run and popped it, or something else. I mean, you have to question how good the tendon tissue is to start with. Obviously, there's protocols to follow, and there's not much wiggle room in those in the first 12 weeks. You've kind of got to follow them. Not wait for a couple of weeks and work some heel raises, to progressively reducing those heel raises, to eventually taking the boot off and starting some really light resistance-based exercises. I don't particularly like stretching Achilles ruptures at any point. For me personally, if they've got 10 degrees subacromial dorsiflexion, when I measure it the first time, I'm pretty happy with that. I think the risk of stretching it is lengthening the tendon tissue and then creating really poor length relations within the tendon and the musculotendinous unit, which will reduce power later on down the line. So I don't think you'd like to stretch them. If I want to get a bit more range, I like to foam roller stuff to the muscle bellies, and chipping away at that. But then after the 12-week markers, you're starting to ramp things up a little bit more. Still following the same process as I sort of mentioned earlier, but I just find it's really slow going, and it's really hard work to get that power going. I unfortunately don't have the opportunity to follow people up 12 months, 18 months down the line.
They're a long-term impact.
Yeah. Like it takes probably at least 12 months to recover from that, and how far you go, I think there's a lot of limitations. So I'm kind of at my limitation when they get to about 6 months, of what I can do and see them in the public system, and they're never as good as they want to be by that stage. But I think a lot of tendon loading, stretch shortening cycle work is important, I think. And starting off with just some, not challenging it too much, but starting off with just like jumps, trying to build that power there without even going to plyometric work, but chipping away at that for a bit, and then more and more work on that plyometric work. But look, it's bloody slow going, and it's not satisfying to work with them because the progress isn't satisfying. It's always satisfying to work with someone that's going to the goals and things like that, but the progress is really slow. It's slower than anything else. It's a lot of hard work. I don't know what it's like in younger people with traumatic injuries or tendon severing and things like that, but it's hard.
I'm dealing with two. Oh, sorry, go on, Connor.
Do you see them post-surgical, or do you see conservative management through public system more often?
No, I always see conservative management. I might have seen one in the last 10 years, and that was because something fell on his ankle. He was a bit younger, something fell on it, and that's what caused it to rupture. Fell on it and cut it or something like that. So I don't tend to see them. It would be interesting to hear from you guys if you've seen the surgical managements and how they go. The conservative ones are slow, partly because maybe it's conservative, but also partly probably because of the fact that the tendon's a bit older and not that great to start with.
Well, I guess we should just briefly mention all of the intrinsic factors in a person that can, I guess, go in with that tendon. So, I mean, if someone is on medications, especially like your corticosteroid medications, if someone has like a really poor diet, if someone is, what are the other ones off the top of the head? Can you think of any, Connor?
Fluoroquinolones, those antibiotics,
yeah.
Those ones. If you've been diabetics.
Yes, the health conditions. Yes, so there's
diabetic,
heart
conditions. Yeah, any vascular problems,
your hormones,
all of these
menopause.
Yeah, and especially like being an S&C coach, you have a little bit. It's weird. You have a little bit of a scope of practice in diet stuff as well. So with at least my athletes, I'll kind of, when they're going through any of these like tendon related issues, we'll do a little bit of counseling on reading the guidelines regarding kind of protein intakes and kind of vitamin C intakes, those type of things as well, because they're things, I guess, help rebuild kind of collagen and protein synthesis and tendon protein synthesis. So definitely kind of factors there that are important. And yeah, I was just going to say, I'm dealing with 2 surgical repairs at the moment, and it's really interesting. So I treat them a lot like an ACL, as in they have to go through the similar time if going to return to run. But it's interesting. I've found that a lot of them can do the like going back to your dynamic systems theory, the body just figured out a way to work around, like they can't single leg calf raise yet, but you go and test and they're like, they can hop 70-odd%, they can jog, and it looks almost like normal, and they're just like, it's just really interesting. One of the very last things to come is the actual plantar flexion strength, maximal strength. They actually like can work around it and achieve all of their tasks within that kind of, I don't know, 6 to 9 months, but then they still don't have this like isolated plantar flexion strength for a while. That does take quite some time.
Really hard. It's really hard. And it's really hard. And that's where maybe I wonder if at that point where they're allowed to, adding heavy loads, whether you're a straight knee or a bent knee, type of a calf raise or both, maybe works. And then getting, when they're ready, when you're happy for them to run, some of those running drills like those dribbles or simple hops with a straight leg or any other sort of running drills that you can't cheat on. You know what I mean? Where those muscles have to work in a sort of isometric or quasi sort of isometric fashion, where you load up the tendon and gain that there. Just hopping, broad hop or vertical hop. Yeah, like you say, it's easy to cheat, but it's really hard to get that plantar flexion strength back. Really hard.
That's what I found as well. We had we actually had this as a case study last week at our in-service. I had a Achilles tendon rupture guy who was managed conservatively, going really well, and I was just going through the continuum of loading. So got him through like isometrics, then isotonics, and then I was really finding that even if I loaded him up bent knee, like this guy is a 90-kilo guy, and he could bent knee like raise in the Smith's machine 100 and something kilos, and he could do it like 10 times. And then I couldn't get him to do a single leg heel raise though. He could bent knee heel raises. He could do hopping. He could even jog across the street. So I was kind of uncertain as to whether to, like, well, not that I allow or disallow anyone to do anything, but how safe is it that he can't generate this force, but he can still go out and run? Would you allow them to jog and things like that, or?
I did.
Yeah. Look, I think if you've done that, you can see that he can, for that guy, he can tolerate putting load through that tendon body weight for starters, plus say 100 kilos as well on a Smith machine.
Yeah.
So, there's at least 2 to 3 times body weight there. If you're moving, that'll add a little bit extra. So I probably would short distances. Again, starting easy and then building up and seeing how they feel at the time, and then how it responds the next day, and using that as your guide to ramp it up.
Yeah. That's kind of what we came up with as well in the clinic, because there was a few of us who would say, "No, keep him off it until he can do a Q raise, and then go from there." And then there was a few of us who were like, "Oh, but if he can hop and he doesn't get any pain with it, just let him do it." So it was a weird one. I've never experienced anything like that with any other joint or any other injury, but yeah.
Let's finish off with talking, say, injury kind of prediction, prevention, risk minimization, late stage rehab stuff. So with ankles and feet, what are you thinking? Kind of injury risk identify, like what puts someone at a higher risk, do you think?
Yeah, look, for me it's always, sorry,
or the evidence kind of shows.
I think from what I'm aware, evidence sort of shows that if they've had a previous ankle injury, that's probably the biggest predictor of whether they'll have another one. Mm-hmm. Dorsiflexion mobility is probably another one, and strength. But how do you quantify strength? Mm-hmm. What's your measuring tool for that? Is it single leg calf raises? Is it hop? Is it absolute strength? Is it isokinetic or loaded strength? I don't know enough about that. I certainly find in the clinic and with the footy guys, one of the best ways to see whether they've had a previous, probably lower limb injury, not just ankle injury, but getting them to do something like a triple crossover hop, and that, either side, and seeing if there's a difference. And 9 times out of 10, it just seems to expose a previous injury. Even if they said, no, I'm fine, yep, no injuries, no previous injuries, do it. There might be 50 centimetres, 70 centimetres difference. Why have you injured? Oh, yeah, I did my ankle 2 years ago. So I find that exposes it a little bit because it's plyometric and there's a bit of change in direction. So that's probably my best tips in looking for that plyometric ability. There's probably heaps of others. I know Mick Hughes looks like a lateral hop, which is probably a really good lateral hops in 30 seconds. I know that's probably a really good predictive factor as well, or gives you a good indication of strength, plyometric ability, endurance. That's what I use.
Nice. And I think that the clinical practice guidelines also mention like the proprioception again, but as I think we'll talk, lots of these things, basically a primary first time ankle sprain is very, very, very hard to prevent or kind of predict realistically. The chronically, like the secondary onwards, you can have quite good targeted interventions once someone has had an ankle sprain. But I mean, the first one, short of taping everyone's ankles, that's not even going to prevent it. It's kind of just trying to apply a really good strength and conditioning program that covers hopping, landing, jumping, proprioception, strength, change of direction. Well, Scotty, you're huge on doing like ankle, like preparatory work, like things that stress the lateral ankle ligaments.
Well, not just that, but I think as a lower limb injury kind of prevention, I think that's really good. Those wide arcs, those skipping and hops, jumping and landing and sticking, that sort of stuff. So something you need sort of ACL stuff. I think it all works together. And I know last year at Valleys, we did that. And I think we had over the people that regularly came to training, I think we had 3 ankle sprains, and we had about 5 or 6 calf strains, I think. So more calf strains than I'm happy with, but not a lot of ankle sprains. And I could have been completely lucky that year. Personally, you know, my ego likes to think it was some of the stuff that we did in the warm-up that made a difference, but, you know, it could well have just been luck. So hard to say. But I think in a warm-up or an injury prevention kind of program, I think that's sort of the lateral stuff, the curves, the change directions. I think that's fantastic, and I think any program that's worth the salt to try and reduce injuries has got to have that in it, whether it's the knee or the ankle. You know, bang for buck.
I agree with that. It's good. I'm kind of got a question. I don't know if you want to talk about it now, but I know you've kind of thought about it previously, Steve, in regards of like kind of preparing the lateral ankle, like that ligamentous complex force strain, like actually exposing it to lower amounts of strain, say, for instance, walking on the lateral edges of your feet and getting them to do things like that. Is there, do you guys
reactive perineal drills, standing on the edge of a step and kind of letting it almost roll and bringing it back?
Yeah, do you guys think there's any value in doing that kind of stuff? Because obviously it'd need a fair bit of force to kind of actually make the ligament thicker or tougher. Like, do you think it's worth doing?
What do you reckon, Steve? You do it?
Well, yeah, it's where my head was going. So I don't know. I'm just like, we're trying to think of different ways to prevent something that is showing that it's unpreventable, I guess. But so there's no study or research into it, but that's my head goes into thinking, let's try to prepare it for the worst scenario and onwards. So might be something that we did start doing it this year. So we did lateral walking, we did toe walking, we did heel walking, and we were starting to, it was in a periodization, that was a start, and then later was going to be, but then COVID came, doing reactive perineal drills, standing on the side of a step and basically getting the guys to try to roll their ankle and pull it back. We didn't get to run that experiment out, unfortunately, but it's definitely something that I am interested in.
I mean, I see your reasoning there. And the proof's in the pudding, really. Yeah, unfortunately, you didn't get to follow the whole way through. We've been really interested to see whether it made a difference or not. From my point of view, personally, I don't like it. And I think from a risk-reward basis, what's the risk of these people injuring themselves?
Not disagreement, but a good little differing of opinion that we have regarding the use of kind of trying to do some primary ankle prevention strategies. And so, like, I'm more on the side of let's give it a crack with trying to work on some trying to increase the strain and maybe hypertrophy of the lateral ankle ligaments, etc. No idea, not evidence-based, nothing, just me trying something different. And you were kind of going on the other way, so I'll let you finish your point there.
Yeah, so it's not something I would go for. I think risk-reward on that. What's the risk of injury in the first instance? My coach wouldn't be happy if I had someone out because of that. But also that basic fifth, that is a bit sensitive. And I guess you build tolerance to that, but still a bit sensitive. And the other thing that I would question is that what are you trying to hypertrophy? I mean, it depends how you're doing it, right? But if your tibia is vertical and you're in if your ankle's in a 90-degree angle dorsiflexion or plantar flexion, whatever way you want to put it, what ligament are you stressing going into inversion? And is that doing the same thing? Is that going to help everything around that sort of lateral ankle complex,
that's
or
true.
not, or is it just going to help one? So,
Yeah, that is true.
in terms of bang for buck, it's not my favourite.
Yep.
Certainly doing some, when I started some SSC work, it was hard fitting everything in. Like, you know, like as much as you think you're going to have so much time to do all this sort of stuff, there's not enough time to do it all. So I really like that lateral cutting manoeuvres. I like the wide arcs, because you can put it into like a field warm-up. It can help with ACL prevention as well. Just lateral movement puts the ankle joint in different sort of angles as well. So yeah, personally, that's my preference. And luck or skill, it worked well for me last year, so that's what I've done again this year to see what happens.
I'll agree with you definitely on that biomechanical point there. Yeah, the ATFL won't be, which is, I guess, the primary one. Yeah, unless you are kind of plantar flex and inverted. If you're kind of missing that, you're kind of almost missing that as well. So
yeah, I mean, if you've got to do something, you know, have a go, see what happens. Obviously, COVID throws some things into the mix there.
I think Connor's got another question.
Yeah.
This would be my last kind of curly question, and I thought that you might be good for it because you went to that podiatry course. Just kind of, where do you see the role of orthotics, and especially kind of long term? Because a lot of people say, "Oh yeah, I've got to wear orthotics for the rest of my life." Personally, I don't know if that's kind of the way to go, but yeah, kind of what do they say?
Firstly, I'm not very prescriptive with my orthotics. I don't pretend to know everything about it. I don't pretend to have, you know, any kind of training for what is perhaps a deformed foot or a diabetic foot. So I'm certainly talking out of the scope of what I know, talking about those ones. But I tend to use it mainly to offload structure, to give it some breathing space, to give it ability to recover, to give it some relative rest, and then to begin reloading it. So my opinion from that point of view is, if you're going to put someone in orthotics, you've got to have a plan to get them out of it. But that's dependent on a couple of things, right? It depends how much work the person wants to put into it. You know, if they're not willing to go through these drills, and they're hard drills, you know, I think you've got to train people to be at least 25% better than what they need to be. And if they don't want to put in that work, that's okay. And if an orthotic gets them out of trouble, if it gets them out of a jam, fine. They've just got to be aware that they need to use an orthotic every time they need to do that, because they haven't then put their tissue structures under that stress to retrain them and take that load to do it without an orthotic. But I think it's like putting a wrist brace on or putting a sling on a shoulder. You know, if you're going to do it, you know, it's hard to do it forever.
Yep.
So that's how I would approach it.
Yep.
So offload a structure and then train them out of it.
Yep.
That's how I go. Definitely.
Yep.
Awesome. That all, Connor?
Yep, that's everything.
Awesome. Thanks very much, mate. That's been a huge chat today. Sorry we've kept you so long, but it was really interesting.
No, it's a pleasure.
Awesome. I'll put up do you want to put up a link for where people can find you if needed?
Yeah, just my email address, which is just scottmcgufficke@hotmail.com.
Awesome.
Probably the best one.
Awesome. Well, thank you very much, Scotty. This has been a big podcast talking all things kind of feet, ankles, lower limbs. So we'll catch everyone later. Be on the listen out for Connor's summary.